Hi, everyone, and welcome to the March MDH Stroke Program monthly webinar on quality improvement. Many thanks to those of you who tuned in the first time. We apologize for the technical difficulties, but we still wanted to provide this webinar to you all. This is Nikki Anderson, the Stroke System Nurse Specialist, and thank you for joining us today. We wanted to share a quick reminder that our monthly webinar series has changed since 2019. We will continue to cover rotating topics, but this webinar will occur on the third Wednesday of the month rather than the fourth, with the exclusion of July and December. Today we're going to cover quality improvement examples, and release our new MDH Quality Improvement Awards program. The objectives for today's QI webinar are as follows. Describe quality improvement and how it relates to designation of any level. Provide an example of QI work that your program has completed. State the purpose for the QI Awards program. And an added bonus to spending 30 minutes of your time viewing this webinar is that you will receive a 0.5 contact hour certificate once you complete the survey. The survey link was included in the email we sent with the recording, and also the link for the survey is in the description text underneath the video title located in YouTube. I do want to point out that we have a few references available on the stroke program website specific to quality improvement for stroke programs. We will share the link in our follow-up email for the PI guide. And for those of you just getting started, or for those of you looking for ideas to support performance improvement efforts at your programs, this guide might be the resource you were looking for. Now let's talk about the basics of quality improvement and how QI applies to designation. So what is quality improvement? Well, it's a systematic, formal approach to the analysis of practice performance and efforts to improve performance. CDC describes on their website that hospital programs actually use interchangeable terms for quality improvement with the same principles at heart, such as continuous quality improvement, performance improvement, Six Sigma, and total quality management. QI in stroke programs derives from guideline-driven protocols, order sets, checklists, and algorithms for treating acute stroke patients. A few places where the guidelines come from is the Brain Attack Coalition, which is the basis for the development of the Minnesota Stroke System criteria, the AHA guidelines, and the Neurocritical Care Society, just to name a few. There are measures and metrics that apply to many aspects of stroke care, written by the certifying bodies. Know your measures. For the MDH Acute Stroke Readies in the audience, your best clinical resource for the measures would be the data dictionary. Get with the guidelines hospitals should reference their coding instructions and also utilize the Joint Commission or DNV written standards. By creating a QI program within your stroke program, you will establish a culture of quality, one that will aim to improve the care you provide and that will lead to a direct impact on patient outcomes. It's important to determine and prioritize areas for improvement. Collect and analyze your data, track performance, and identify trends. Make it meaningful and do something with it. Communicate your results to administration, team members, and even us here at MDH. Continue to monitor for the need to make adjustments, and when it's all said and done, celebrate success. Success can come in many forms, even if it's not the outcome you were hoping for. It could simply be the completion of a project. Here's an MDH example of how to share your results with administration or other team members. In quality improvement, a storyboard is a graphical summary of a completed quality improvement effort. Sharing storyboards is a great way to communicate team initiatives and to keep quality improvement top of mind. Through celebrating success, you will foster a culture of recognition. Not all of us would want to stand on a podium to give an acceptance speech in a room full of 1,000 people. Yet, the vast majority of us appreciate a solid acknowledgement of a job well done. By celebrating success, it will increase morale and engagement. This will strengthen relationships and teamwork and hopefully lead to improved staff performance. Recognition can be as simple as verbal praise. Hey, Jess, great job calling that stroke alert the other day. It was a tricky case, and assembling the team involving telestroke was the right thing to do. Verbal and written praise can also be shared amongst team members. Some idea for written praise includes sharing success in newsletters, emails, or posting on performance boards. Another example would be the storyboard shown a few slides ago. Awards can create a healthy level of fun competition within the department. Identifying team members who had the fastest treatment times or great catch awards are a simple way to acknowledge a job well done. Awards can come in many forms as well. One that we all would likely appreciate is food, and you can even target what staff would appreciate and use that as incentive to improve performance. So how does QI connect with designation? Honestly, it affects all levels from acute stroke ready to primary stroke centers and comprehensive stroke centers. This is an excerpt from the DNV Comprehensive Standards. It states that leaders must commit resources to support, evaluate, and improve services. We took this screenshot here from the Joint Commission website, which states that stroke centers, as well as those seeking certification, are required to collect data for standardized performance measures. In addition to collecting and reporting this data, organizations are expected to use this information for ongoing performance improvement efforts. Which now leads us to MDH Acute Stroke Ready Hospital designation and where PI ties in. Here is a screenshot directly from the designation reference guide. This criteria requires a commitment to continuous quality improvement. There are many models and tools available to use for your QI efforts. It really varies on which process will work for what you are trying to accomplish, and specifically what is going to work for you as an individual. A few are listed here, and we will walk through a case using the DMAIC process over the next few slides. DMAIC stands for Define, Measure, Analyze, Improve, Control. Let's start with the first step, define the problem. Identify the need and process to improve. For this example, we are going to use the door-to-needle measure. Current performance is door-to-needle median of 75 minutes. The program goal is a goal of 60 minutes or less. There is our problem. We aren't reaching this goal. The next step in the process is to measure. Measure process performance by assessing current performance baseline. What is the gap between expected performance and current performance? The program stroke coordinator scheduled a meeting to discuss the door-to-needle measure. They invited the medical director, nursing manager, and pharmacy to discuss the current performance and process. During this meeting, they continued to work through the DMAIC process. Then, they analyzed the process by discussing what currently happens when the decision to treat is made. So here is their current process. The neurologist makes the decision to treat and quickly discusses this with the ED provider. The provider puts in the order for alteplase. Nursing then calls pharmacy when they are in-house, and these hours vary, to notify pharmacy of the order. Pharmacy mixes in their department and then walks to the ED to hand off. And now, analyzing this process further, some barriers or time-consuming steps were discussed. Pharmacy hours will certainly vary, and when they have a pharmacist in-house, that's it. There's only one pharmacist. Their ability to answer the phone in a timely manner is a challenge, and the distance between pharmacy and the emergency department is 2 floors and on the opposite side of the building. Logistics are not working in their favor. Now, once the alteplase order is placed, it's lumped into all of the other pharmacy orders in the EMR without identification that it's a stat order. The emergency department manager discussed the comfort level of mixing IV alteplase at the last nurse staff meeting, and staff expressed that they had low confidence. They also expressed that it's also challenging for them to call pharmacy while trying to provide direct patient care, and sometimes it takes multiple calls in order for someone to answer. So the next step in the DMAIC process is to improve. Make changes to improve the process, brainstorm solutions, anticipate risks, and create a plan. So after discussing the process and identifying these barriers, it was clear to the team that they needed to establish a consistent, streamlined process for mixing IV alteplase. Due to pharmacy's variability of hours and their ability to respond in a timely manner, it was determined that nursing was the best, most consistent option. A rollout plan was then developed. The pharmacy department was going to develop an IV alteplase hands-on nursing education competency. Depending upon nursing's confidence level, the competency may also be offered more than annually. There is always a code response nurse and supervisor on for every shift. They felt it was best to consider this batch of nurses as the designated mixers, since there is 2 on every shift. They updated their policy to reflect this change, and now all the ED nursing staff is going to receive the education. Pharmacy is going to create a stroke code kit as well, which contains all of the materials needed for dosing, mixing, and administering IV alteplase, along with the resources for reference. The alteplase order will be flagged in the EMR and will move to the top of pharmacy's list as a priority. The pharmacist will call the emergency department and let them know if they can respond to the bedside. If they can, they will be a second set of hands and eyes for the mixing process. Nursing is not to wait for pharmacy's response to mix. After the plan was implemented, we moved into the control phase to maintain improvement. The plan was to monitor door-to-needle times over the next 12 months and meet bi-monthly with the team to discuss cases and reassess the need for change. And here are the results mapped out. The plan was implemented on May 1st, and as you can see here, there has been a significant downward trend in door-to-needle times. The staff continued to meet bi-monthly to reassess the need for change. At their December meeting, they decided to adjust their door-to-stroke metrics to align with Target Stroke Phase 3 and are now striving to achieve a door-to-needle time of 45 minutes or less. With that, I am delighted to introduce Ann Reuter. Ann is an RN who spent 8 years as a bedside nurse in Abbott Northwestern's Med-Surg Neuro ICU, then transitioned into the world of healthcare quality. She has been the Director of Quality at Northfield Hospital Plus Clinics for the past 20 years and joins us today to share her team's performance improvement experience as an acute stroke-ready hospital.
Thank you for inviting me today, Nikki. I want to start first by telling you a little bit about us. Northfield Hospital and Clinics is an independent 37-bed community hospital located about 30 miles south of the Twin Cities metro area. Our health system also includes 7 clinics, a home health care and a hospice agency, a long-term care center on the lower level of the hospital building, and an ambulance service. Next slide, please. Our problem was identified as we were doing case review on a number of different diagnoses and noting that the ED length of stay was sometimes too long. Since we really weren't finding any trends on where delays were occurring, we were just sharing the length of stay data on a regular basis with the staff and physicians and continued to encourage best practices for each of these diagnoses to reduce the length of stay. Next slide. Then one day I got a survey comment from an acute MI patient who felt it took too long to stabilize him before transporting him to tertiary. And as we investigated the patient's concern, that case review revealed that 59 minutes had elapsed between the time the patient was ready for transport and his departure. Granted, much of that time was spent making calls for transport. Dispatch had tried 3 air ambulances and found out that none of them were flying due to the weather. So our ambulance service was called for ground transport. Once they arrived, it still took 18 minutes for the handoff, and when I shared this finding with the staff, they knew we could do better. Next slide. As we brainstormed with the ED and EMS leadership staff, I think it's important to point out that they first acknowledge that there are three major life-altering diagnoses in which frontline caregivers have a huge opportunity to affect patient outcome by rapid diagnosis and treatment: acute MI, stroke, and trauma. So this was established as the why behind any performance improvement strategies we would be putting into place. That need for speed is an essential shared mental model when the patient presents. And so we use the image of Speedy Gonzalez to help remind staff of the why and the when we have to switch into high gear. Next slide, please. The staff immediately told me that the most time-consuming step in the handoff was switching over the IV from the ED pump to the EMS pump. Interestingly, this is a budget thing at our hospital. Each department has to purchase their own pumps and has to account for them at their annual inventory. So that's why the switch was taking place. Next slide. Once we approached the administrative team and recommended the ED and EMS share the pumps in both their inventories, we abandoned switching the pumps and traded them instead. The paramedics bring a pump with them, leave it with the ED, and so they can just take the patient as is. Next slide, please. This alone shaved a couple of minutes off the average handoff time frame. Next slide, please. The next strategy recommended by the EMS team was to adopt a more structured, standardized handoff for report to ensure more concise reports and less interruptions. The 20, 60, 30-second structure is illustrated on the link I've provided on the slide, and this was used as part of the education for staff prior to putting the strategy into place. Next slide, please. Although it took a while for the learning curve to occur, we did hit our goal of 10 minutes in the third quarter for all of the patients transferred to tertiary by our EMS. And next slide. For stroke patients, we're averaging a 12-minute handoff. Next slide, please. So we still have work to do, and the challenges remain: maintaining engagement of the staff and soliciting additional strategies to reduce that length of stay. Next slide, please. On these last two slides, I've shared some of the tools we use specific to this project. The first is an SBAR communication to the ED and EMS staff introducing the why, when, what, and how of the project. And on the next slide, please, are some visuals that we consistently use as we communicate the data and the progress with the staff. So with that, I'll turn it back over to you, Nikki.
Thank you so much, Anne, for sharing your PI project here today. It's examples like this that have led us here at MDH to develop an awards program. There is so much to celebrate, and we want to foster a culture of success with all of our partners. As you know, there are 116 designated stroke hospitals in our system. QI is embedded in every program, and with that, we know there are some really great things happening all over the state. We'd like to recognize and showcase successful QI initiatives at the Minnesota Stroke Conference and on the Minnesota Department of Health Stroke Program website. There will be an application process for the awards program, and the QI initiative should be current and started within the last 12 months. We will send out an email in the coming weeks with the details on the application process. All applications can be sent to Nikki Anderson starting April 1st through August 31st. The application includes a narrative, results, and photo section. For the narrative, please include the following details. Describe how you identified the focus area for improvement and what team members were involved in the development of the plan. Describe the quality improvement plan, including the goal, activities, and the monitoring of performance improvement metrics. Describe the steps you took to implement the quality improvement plan and include any encountered challenges and how they were addressed and/or how the plan was changed in response. The next part of the application is the results section. Summarize lessons learned, describe the results, and include a visual to show the changes in performance. And lastly, to make this fun, include a unique program-specific picture. It doesn't have to be crazy. It really can be simple and normal, but we do encourage you to make it fun. At this time, I would normally ask if there were any questions, but since this is a recorded webinar, if you do happen to have any questions after viewing, please feel free to send us an email at our MDH stroke email address, or you can email me personally at nikki.anderson@state.mn.us. Again, the link to the survey was included in the email of the recording, and it can also be found on YouTube in the description text underneath the recording. And that's all we have for today. Again, I'd like to thank Ems so much for sharing their excellent example of QI. And please join us in the month of April for our monthly webinar. And we look forward to talking to you all then. Stay well and take care.